This is Dr. David Kaufman with the editorial board of the Clinical Neuropsychologist. Here at TCN, we are interested in showcasing dialogues with experts in the field of clinical neuropsychology. Today I am joined by Dr. Rodney Vanderploeg, who will be talking with us about post-traumatic stress disorder and traumatic brain injury in veterans. Dr. Vanderploeg is the supervisory psychologist for neuropsychology and brain injury rehabilitation at the Tampa VA, and he is a professor in the Department of Psychiatry and Behavioral Neurosciences and the Department of Psychology at the University of South Florida. Dr. Vanderploeg, thank you for joining us today.
It's my pleasure to be here.
Dr. Vanderploeg, you have conducted a variety of studies on traumatic brain injury and examined how TBI can co-occur with PTSD in veterans. Can you tell us how often veterans return from duty with symptoms of PTSD? Is this a significant problem?
It really is a very significant problem. Within the Department of Veterans Affairs, about 30% of individuals returning from combat environments at one point in time will present to the VA with PTSD seeking treatment for it. I would say that's a pretty significant problem.
What appear to be the most effective treatment options for veterans with PTSD?
The VA really focuses on evidence-based treatments and has reviewed the literature and set up clinical practice guidelines around that. And they've also instituted basically educational training sessions followed by supervision of actual cases for mental health providers within the VA. And the currently approved or recognized evidence-based treatment for PTSD in the VA are prolonged exposure therapy and cognitive processing therapy, either with or without adjunctive psychopharmacology, which typically is either the SSRIs or the SNRI, venlafaxine.
One of the evidence-based forms of psychological treatment you just mentioned is called prolonged exposure therapy. Can you tell us more about that form of treatment?
Prolonged exposure therapy is typically done on an individual basis with a therapist and individual with post-traumatic stress disorder. The sessions typically are 90 minutes, a little bit longer than the typical 60-minute session because more things need to be done over the course of that 90-minute appointment. But in general, prolonged exposure therapy starts out with a session or so of psychoeducation, both about PTSD and its symptoms and how they sort of reinforce each other, as well as the theoretical rationale underlying prolonged exposure therapy. Also, early in treatment, there's typically some relaxation training to help individuals manage their symptoms. But the core, really, of prolonged exposure therapy is exposure. It's exposure to the primary trauma memory or trauma event that the individual tends to re-experience or remember. And it's talking about it and going over and over and over again, talking about that event, one's experiences of that event, one's thoughts and feelings. And by the exposure, you, over time, decrease the potency of that so the individual gains control over their reactions to it and their thoughts about it. Within the therapy session, there's often imaginal exposure where the therapist will ask the individual again to talk about that particular traumatic event, or if there are more than one, over time to talk about one or two of the traumatic events, and again going over and over and over it again. But there's also homework assignments, because typically individuals with PTSD, to manage and control their symptoms, they avoid things. They avoid going out in situations which activate the symptoms, cause them anxiety, or result in them sort of re-experiencing the trauma and the anxiety. And those may be going to a shopping mall, going to a movie, whatever they might be. And so the homework assignments, after the individual has gone through some imaginal exposure and developed some control, would be on their own or with somebody else going out into a real-life situation that they have been avoiding, and utilizing the relaxation training and sort of the cognitive processing that they have had within the individual sessions. The course of prolonged exposure therapy usually is somewhere between 8 and 12 sessions. Usually all of the main elements are completed within 6 to 7 sessions, and then there's additional elements that may take place over another 3 or 4 sessions after that.
With the high number of veterans returning home with PTSD, a big question is how a TBI may complicate their recovery. What are the ways that TBI affects PTSD treatment outcome?
Well, many of the individuals who are deployed to a combat environment develop PTSD from multiple traumatic exposures. Within those traumatic exposures would be things like a firefight, seeing somebody wounded or killed who's right next to you, or driving down the street and seeing the aftermath of a IED explosion and individuals wounded or killed on the street. But they may also experience a traumatic brain injury themselves. And typically in a combat environment, that has not only the physical injury of a concussion or a mild traumatic brain injury, but the same kind of combat traumatic and emotional experiences associated with it, with, again, individuals being wounded or killed, dying next to them, or having to commit, take someone else's life in defense of your own or your comrades. So it's basically an additional both physical trauma but also psychological trauma that would need to be dealt with in the course of treatment for PTSD itself, whether that's prolonged exposure therapy or cognitive processing therapy. However, the effectiveness of prolonged exposure therapy or cognitive processing therapy is not diminished in any way whatsoever by having a comorbid traumatic brain injury. That's been demonstrated to be true both if the individual has a concussion or a mild traumatic brain injury, but also individuals who experienced a moderate to severe traumatic brain injury. That once they have come back, gone through brain injury rehabilitation and recovered to a certain degree, at some point they would then engage in psychological treatment for their PTSD, and having comorbid traumatic brain injury does not diminish the effectiveness at that stage of the game. The outcomes are virtually identical for those who have comorbid TBI as well as those who do not.
For veterans with comorbid PTSD and mild TBI, what are the best treatment options?
Well, it's interesting because we completed a study here at the Tampa VA looking at prolonged exposure therapy for individuals with comorbid mild traumatic brain injury and PTSD. And they are involved in ongoing rehabilitation for traumatic brain injury, mild traumatic brain injury, which may include physical therapy, vestibular therapy, medication management for headaches, maybe other types of treatment for speech therapy, engaging them in sort of cognitive rehabilitation treatment, both compensatory strategies, but also sort of practicing various kinds of attentional tasks to help build up attentional focus and attentional control. And at the same time, they're getting prolonged exposure therapy. And we've analyzed that data to look at both the outcomes in terms of things like PTSD outcomes, as well as depression, anxiety, and just general psychological or functioning in everyday life. Almost all of the variance in outcome is associated with prolonged exposure therapy, meaning that those who get prolonged exposure therapy and complete their treatment trial have excellent outcomes comparable to individuals who don't have TBI and go through prolonged exposure therapy. The additional benefit of the traumatic brain injury rehabilitations, cognitive rehabilitation, vestibular therapy, headache management, really provides minimal additional contribution. But having said that, many of these individuals are not willing to seek mental health treatment initially as their primary treatment focus. If they believe that they have sustained a concussion or traumatic brain injury. Often their belief is that all of their symptoms are due to that concussion or traumatic brain injury. And so they're willing to walk through a treatment door that's for brain injury rehabilitation, where they may not be willing to walk through a door that is a mental health treatment like prolonged exposure therapy or cognitive processing therapy. But once they walk through that door and you establish a relationship and you treat all of their complaints very seriously, and engage them and educate them about their psychological reactions and how those psychological reactions are consistent with PTSD and that we have a very effective treatment for it. Once they're walked through that rehabilitation door, they're often willing to engage in mental health treatment, such as prolonged exposure therapy. And when they do and complete it, they show excellent outcomes.
So in your research, prolonged exposure therapy is responsible for the bulk of treatment outcomes for veterans with comorbid PTSD and mild TBI. Yet, many veterans perceive their difficulties to be a consequence of their concussion, and may even be reluctant to seek treatment for PTSD. It seems then that a major challenge for recovery in this population is the difficulty that many patients have in recognizing the importance of their psychological distress. And without a willingness to seek evidence-based treatments like prolonged exposure therapy, many veterans will miss out on these positive treatment outcomes. Is that correct?
That's absolutely right. And I would say it's not only an issue for patients in terms of believing that their symptoms and problems really are all related to a concussion, but it's also the case for many treatment providers who are either misinformed or underinformed about the effects of mild traumatic brain injury in the chronic phase and are believing that the majority, if not all, of the symptoms and problems are due to that traumatic brain injury, failing to recognize the psychological concomitants like PTSD or depression or substance use or other kinds of issues. So it's an educational opportunity for both patients as well as providers.
Well, Dr. Vanderploeg, thank you so much for sharing your expertise with us on this important issue. And best of luck as you continue working with veterans and their providers to ensure quality treatment outcomes.
Thank you very much. It's been my pleasure.
If you have further interest in this topic or want to read up on the latest research findings in clinical neuropsychology, please visit us online or check us out on social media. I'm Dr. David Kaufman, and on behalf of the TCN editorial board, thank you for listening.